Thanks, Partha. I hope you didn't say nobody better who can create these complex situations. Okay, anyway, I'll be talking about, let's say, what we call think outside the box. ICL today is something that personally I've been doing for more than 17 years today. I think possibly the first ICL implanted in India was done around that time only. The only thing is that with predictive results and outcomes that you are getting with the ICL today, the ICL is a tool where you can kind of make the patient outcomes much better in complex situations. So let's be adventurous and let's look at a couple of situations where we could use the ICL to make things better. Now, these are the three things that I'll be talking about, and let's just look at these three particular situations. Now, when you are having a refractive correction that you need for post-LASIK ectasia or post-keratoplastic patients, these are the two things that I am going to discuss. What are the important parameters that you need to have? The first and the foremost important parameter is stability. You need to know that if you have done a cross-linking, you have done an intax, or it's a post-PK, you should wait long enough for the topography and the refraction to be stable, and that needs to be repeated because that is something which is very important. If there are sutures in situ, you should remove the sutures and then wait for the stability and then go ahead with an ICL, because that is something that you would wish to take. So that is one important thing. The second important thing that you have to know is that if there is a cylinder or there is an astigmatism which is primarily being contributed by the back surface of the cornea, that is not going to give you great results with an ICL. So that means that the patient should have good spectacle corrected vision. That is when the ICL is going to work. If the patient is getting 6/6 vision with a rigid contact lens and not with a spectacle, then that patient is not going to. So that patient will come only to the BCVA that you get with the glasses and give and add the minification factor. So that's the only thing that is there. So you have to have a good best spectacle corrected vision, and you need to have stability. That is what is very important. Now, this is what we are doing in these particular cases. So I'll show you a case where actually we have done trioptics. So this is the case operated elsewhere in the year 2010, came back with a diminution of vision post LASIK in the year 2012. So you can see that the patient has in the left eye a diminution of vision that is happening, as also in the right eye. The BCVA, you could see that there is a residual refractive error. This is the topography, and as it is simply seen, this is post-LASIK ectasia to some extent in the right eye, and the left eye you can see that there is a large cone, so there is a post-LASIK ectasia that's happening in this particular case also. So what we have to do in this particular case, those were early days, so we first did a C3R. Today I will not do first a C3R and then an intax. We did a C3R and then we looked at doing an intax. So this is post C3R cornea where an intax is done, but today, re-emphasizing, I do it simultaneously. I do a C3R and an intax on the same sitting. So you can see this is the channel that is being created with the interlace. You can see this is the clover leaf spatula. You are going in with the clover leaf spatula in this particular case. You go in, open up the channel that has been created. I'll just go a little forward. You go to the other side. You can see this is the channel. This is the intax that is being threaded in. When you put the intax, you have to go vertically down and then go horizontally. So you can see this is the intax that one is putting into the cornea. You can see again the intax in situ. And you can see that once we have done this particular thing, this is the second intax that is going in. You can see this is the second intax that goes in, and you put a suture and you remove the sutures at 3 months' time. So let's go on to the next situation that we are having here. You see that the vision has improved to 636 in this particular case. This is -7 with -4. So you saw that the intax has caused a significant change in the refractive error that is there. This is the topography. If you remember the earlier topography, you can see that the cone has become slightly better. Now this is what it is in 2014. So you have a cornea which had a LASIK, you had a cornea which went into ectasia, you have done a cross-linking, you have done an intax, and now you have a stable cornea and you have waited 2 years for this stability to be there. So what we go ahead in this particular case is what you have seen earlier. This is putting a ICL. So in this particular case, you will have, since you had a good visual recovery in this particular patient, you can see that we go ahead, we put intracameral xylocard. You can see that this is the ICL that is being put, just going a little fast forward. So you can see this is the ICL, this is the end of the surgery, nothing dramatic about the surgery. So you had the markers at that time, not the Callisto system, or you didn't have the Varion system, but this is the end of the procedure that you have. And this is the post-op picture that you have. So friends, what do we end up with? We end up with a great vision of a 6-9, which is 2 weeks post toric ICL. So look at the complexity of the situation and the kind of different technologies that have been used in this particular case. So this is what one of the cases that I wanted to say. Now the second thing which we often do is what is known as bioptics. What you understand in bioptics is that it is a combination of 2 different surgeries. That means in one, the power of the individual is so high that neither of the 2 can take care of the refractive error as a single situation. So what you are doing is you are doing a LASIK as also you are doing an ICL. So typically if the power is say 24, 25 and the ICL is going to take care of say -18, what I will do is I'll prefer to do a spherical ICL and not, I'll leave out the toric component in the ICL, but before I do that I will make a flap. So what they said was that the suction can change the, can have some pressure on the ICL. So what you do is you just make a flap and put back the flap without doing any ablation. So that is point number 1. Then you go ahead and put an ICL which is a spherical, wait for 3 months or till you have a stability of the refractive error, go back and just relift the flap and do that. But nowadays with the Visumax, I prefer to do a smile, or you can do a PRK where the suction pressure is not very high. So it is up to you whether you just want to do a flap first and then do the ICL and then do the refractive correction. But what is imperative is that the ICL needs to be done first and then you have to do the refractive correction. So this is just to show you, I'll just show you this is just the normal loading of the ICL. I don't think we need to go into this because you have seen it, Partha showed it very well, and so did Purendra. So all that I am trying to show you, can you see this edge here? Okay. So this is the edge. You can see that this is the flap that had been created earlier. So you have a flap that was created, put back, let it heal, put in the ICL, and then 3 months later you can relift the flap and do the laser vision correction. So this is all that I wanted to show you in the second case, that bioptics can be corrected. Now the third thing which we have done, thinking outside the box, is all of you have the Sulcoflex Rayner lenses for correction of residual refractive error post IOL. So if you can put a thicker lens like a Sulcoflex, why not put an ICL? The ICL is supposed to be put in the sulcus. It is correcting a very high degree of ametropia. Now I had a patient, a congenital cataract that I had operated maybe about 15-17 years ago, and this girl came back with a residual refractive error which was gone to the extent of -13, -14. The Sulcoflex does not make you a lens which can correct -13, -14. So in this particular case, what we did was that we are taking the advantage of an ICL. The ICL doesn't cause pigment dispersal, you know about it. It remains stable in the sulcus, and you can use it both in the toric and the other varieties. So you can see this is a PI done earlier. This is a case with a slight decentration, a 3-piece lens that has been put by me. I think it was a sensor lens that I had put at that particular time in this girl. So you can see all that I am trying to show you is that you can remove the synechia if there are any. You can redial the lens. All that I am showing you in this particular case is this is a 3-piece lens which we are just centering it and putting the haptics in the proper place. You can see it's a tough capsular bag that you have. There is a slight phimosis of the anterior capsulorhexis that has been done in this young girl, and you can see now that the lens is centered. Once you have the lens centered, we just go in and put an ICL in this particular case. She had largely a refractive error, which was a spherical refractive error. So I have used the ICL as a piggyback lens in this particular case. You can see that's the end of the surgery and end of a piggyback ICL that has been done. That's the PI that had been done earlier. So friends, these are couple of the situations that one has thought outside the box. Use the ICL for complex situations which are normally not the indicative things for doing an ICL, and I think this is a great way to take care of them. Today I am using almost 50% of my Phakic IOLs as ICL Phakic, which is another. So today you are getting spoiled for choice. The ICL people who were on a high horse as regards the costing and all attending to obviously will come down in due course. So you have two Indian equivalent of these. The track record is still going to be there, but they have both of them come with a TORIC. So both of them are Gujarat companies. I don't have any financial interest with them, but they are available and you have the ICL. So there are 3 of these lenses that are available and you can work with them even in tough situations. Thank you very much, Partha, for having me on your course. Thank you.
Thanks a lot.